Welcome back, everybody. I hope you had a good break and got some refresh of your coffee. So as I alluded, our next two presentations are going to be, both presentations will be from Liam O'Fallon, who is from our population health branch. And these are our concept clearance approval requests from council. And the first is for the continuation of our Pediatric and Reproductive Environmental Health Scholars Program, or PRESH, as we like to call it. With that, I'll turn it over to Liam and look forward to the presentation.
Thank you very much, Dr. Balshaw, for the introduction, and good morning. Greetings, council members, NIEHS colleagues, and those of you joining us from around the country. It is my pleasure to talk with you this morning about this exciting program we launched in 2021 called the Pediatric and Reproductive Environmental Health Scholars Program. Here's an overview of what I'll be talking about: the program history, the rationale, the accomplishments of the program, and then the request. The success of any program depends on a team of individuals working together. I want to acknowledge the important contributions of my colleagues here at the National Institute of Environmental Health Sciences. On the programmatic side, Mike Humble and Jenny Collins, and then also from the grants management side, with their help in getting this program started, Latavia Miller and Jenny Greer, as we navigated some of those challenges at the beginning. I also wish to highlight our colleagues Linda Hansen and Kimberly Spencer at the Centers for Disease Control and Prevention, Agency for Toxic Substances and Disease Registry within the Office of Capacity Development and Applied Prevention Science for their partnership on this, as well as our colleague Manthan Shah at the EPA Office of Children's Health Protection. So we brought this concept to council back in 2019 with high expectations of a truly bright future. As a representative for our team, I am pleased to be back in front of council seeking your support for the continuation of this productive program. As you may know, for many years, NIEHS has worked closely with the Environmental Protection Agency on the Centers for Children's Environmental Health. When the original Centers program ended, staff established new ways to continue coordinating and collaborating on issues related to the improvement of children's environmental health. One area of agreement was on how to more effectively work with the Pediatric Environmental Health Specialty Units, otherwise known as PESUs. I'll talk about them a little bit more in a minute, which are funded by the CDC, ATSDR, and the EPA Office of Children's Health Protection. Staff saw an opportunity to build on past training model that enabled pediatricians to work with PESUs on outreach and communication efforts and to learn about ongoing research in pediatric environmental health. With consistent funding, a new program could truly enhance a pathway for the next generation of pediatric and reproductive environmental health leaders. Additionally, it was envisioned that this program could address another recognized challenge among healthcare professionals, which was the lack of environmental health knowledge and lack of materials or evidence-based guidelines that enable them to discuss effectively the environmental health concerns with patients. Staff also saw the natural benefit of the program to strengthen the coordination among federal partners at the National Institute of Environmental Health Sciences, the CDC, ATSDR, and the EPA, as well as to identify and strengthen connections amongst pediatric and reproductive health researchers and the PESUs. So you may be asking, who are the PESUs and why should we partner with them? So the CDC ATSDR established the Pediatric Environmental Health Specialty Units in 1998 with long-standing support from the EPA. As a regions-based network, PESUs provide education for health professionals, outreach to and education for communities, consultations on environmental exposures, referrals for evaluation and necessary services, as well as the development of partnerships that promote and support PESU mission. PESU provided services help to reduce the risk of exposures to children and families and mitigate potential health effects before they happen. As you can see, research is not one of the services, which is why stronger coordination and collaboration with the pediatric reproductive environmental health researchers, hopefully NIEHS funded, is so important. Together, the latest research can help to inform new training materials, fact sheets, infographics, and resources to aid with the PACU provided services. So based on this rationale, we work closely with our colleagues at CDC, ATSDR, and the EPA to develop and launch the Pediatric Reproductive Environmental Health Scholars Program. Since 2021, this program has been introducing pediatric healthcare providers, obstetricians, and gynecologists, and other interested healthcare professionals to issues in environmental health, broadly speaking. The program provides scholars with research experiences that bridge clinical practice in environmental health, community-level engagement, teaching, research translation, and communication. The program was designed to meet the identified gaps and needs that I just talked about by providing scholars with personally tailored, state-of-the-art environmental health research training that blends academic research and practice-based applications in real-world settings. The scholars receive supervised research career development opportunities. And through this program, scholars have been gaining an understanding of the many interactions, biological, psychological, social, cultural, that occur between children, pregnant women, and new mothers in their environment. This program is truly expanding a pathway for healthcare professionals who are researchers, resources, and leaders in pediatric and reproductive environmental health. To achieve the goals of our program, we require proposals to possess a partnership between an academic institution with demonstrated strong foundation in pediatric and reproductive environmental health research, as well as a PACU. They did not need to be co-located. The academic institutions were expected to provide scholars with a robust selection of research and mentorship offerings, as well as opportunities for real-world experiences to address environmental health concerns and gain awareness of community-engaged practices. By partnering with the PACU, scholars would learn about environmental health concerns of parents and healthcare professionals, and ideally develop the appropriate materials to meet those needs. Applicants had to outline a comprehensive career development and research plan that demonstrated environmental health research relevant to pediatrics and reproductive health and be within the NIEHS mission. They had to serve as a mechanism for gaining research competencies in environmental medicine related to pediatrics and reproductive health. And they had to provide the scholars with the necessary environmental, public health, and clinical expertise to advance their careers as an academic researcher and physician scientist, such as improving their scientific and grant writing skills, fostering expertise in risk assessment and risk communication. As you'll note, a key benefit of this program is the protected time and fiscal support that the scholars receive for salary, research, and training. As shown here, we made 3 awards to these academic institutions that are partnered with the following PACUs. Over the next few minutes, I'm going to share with you a little bit about the scholars and their accomplishments. Starting with the Mount Sinai School of Medicine Pediatric Reproductive Environmental Scholars Program. Here are their 6 scholars. The left column shown here has the name, degree, and the expertise of the scholar, and the right column provides the focus of their work as a scholar. As you can see, these scholars are bringing a range of knowledge and expertise to the program, and they are pursuing interesting environmental health questions. I'd like to call out Drs. Ramsey and Akinkube and their efforts to make their work accessible to different audiences. Dr. Ramsey is translating her pediatric respiratory work through peer-reviewed journal articles, engaging social media approaches, and with the Region 2, PACU, and the New York State Children's Environmental Health Centers, otherwise known as NICE. Makes me think of the upcoming hockey season. In addition to peer-reviewed articles, Dr. Akinkube, a public health dentist, is applying her knowledge to timely conversations on fluoride and health. She too worked with the PACU and the NICE to develop a prescription for prevention sheet that healthcare professionals can use when talking with parents and patients. I've added a QR code here on the screen in case you'd like to check it out. Moving on to Emory, which is partnering with the PESU Region 4 serving the southeastern states. It is interesting to see that they bring a broader background on biomedical research, bioinformatics, nursing, and midwifery as part of their scholar cohort. You might notice that Doctors Baranduzzi and Wolf don't have any focus identified right now, but that's just because they joined very recently. I'd like to highlight the different contributions of Doctors Aguayo and Katebe to pediatric reproductive environmental health. In addition to publishing her cardiovascular work in a variety of spaces, including Medscape, Dr. Aguayo has received a Career Development Award from the American Heart Association, which is a nice recognition of the work that she is doing in the space. Dr. Katebe has been publishing innovative work on fetal heart monitoring and blood pressure monitoring approaches. Her research is advancing clinical practices and expanding access to quality prenatal care in clinical and remote settings. Also want to note that Dr. Livingston Burns kindly contributed to a PEPH, or Partnerships for Environmental Public Health podcast, on the importance of incorporating environment into maternal and child health care. Finally, at the University of Washington, we see another well-rounded cohort of scholars, including a reproductive urologist focused on wildfire smoke and male infertility. The scholars at University of Washington are translating research that can be used by different groups. In addition, they have successfully obtained pilot funding from the EHS Environmental Health Sciences Core Center at the University of Washington, as well as the Children's Environmental Health Center at the University of Southern California. I'd like to draw your attention to the translational work that Dr. Hash has developed on wildfire smoke and health. In response to community questions, she created an infographic on how parents can protect their children when there is poor air quality from a wildfire event. She's also brought her newly acquired knowledge into an introduction to nursing class that she teaches. In this class, she integrates environmental health examples to advance her students' understanding of environmental exposures on children's health. I know we all like sweets, and Dr. Rezkinoff has created a guidance document on sweet alternatives for the PESU network. This document is intended to help healthcare professionals communicate with their patients about the myriad alternatives and their possible health benefits or risks. I've included the QR code here if you'd like to check out this fact sheet. Finally, Dr. Crocker's work has been recently featured in the NIEHS Factor. She's been developing a toolkit for parents and caregivers that involves gathering input from a variety of stakeholders. The plan is being updated and is receiving feedback. The final toolkit will be posted to the PESU page quite soon. She's also received pilot funding from the Children's Environmental Health Center at USC, University of Southern California, to do work on remote home inspections for children with asthma. This work is exploring the perspectives of parents and community health workers to understand the benefits and barriers to this virtual home visit approach. Dr. Crocker will actually be graduating from the program at the end of the month. So, in summary, we have been training the next generation of clinicians through this program. We are building capacity and leadership of the scholars in multiple clinical specialties, from pediatric pulmonology, emergency medicine, biomedical research, including bioinformatics and machine learning, obstetrics, and urology. It's a whole range. In addition, there are many different research areas of focus in exposures and health outcomes. One of the things that we've been trying to do for the last 4 years is foster scholar interactions. Fostering these interactions through scholar networks is important for a few reasons. It's an opportunity for the scholars to learn from one another. It enables them to learn from current leaders in the field, and it promotes an identity of being a pediatric and reproductive environmental health scholar. We want this program to be recognized broadly, and we want the scholars to be able to say, I was an NIEHS-funded pediatric reproductive environmental health scholar. We also want interested early-stage healthcare professionals to seek out this program so that they too can become a scholar. Of course, it's difficult when you first get started, but we are making strides. Mount Sinai, Emory, and University of Washington have been working closely with their scholars to establish this identity at their own institutions. Programmatically, we've brought the scholars together virtually and in person. In fact, they are coming together, as David mentioned, in October at the annual Pediatric Environmental Health Specialty Unit National Meeting. They will have a panel at the meeting where they will be able to share their accomplishments, in addition to a separate Pediatric Reproductive Environmental Health Scholars meeting. So what's next? We have accomplished a lot under the 4 years, and we would like to build upon the successes by continuing the Pediatric Reproductive Environmental Health Scholars Program. I know our colleagues at the CDC, ATSDR, and EPA share this sentiment. I believe that Dr. Hansen is watching this and has rearranged her schedule so that she could listen into the presentation and hear the discussion. So we are seeking your approval for continuation of the program that has the same vision, purpose, and format. Sure, we'll have some minor tweaks, but nothing major. It will still require the partnership between an academic institution with one or more currently funded PACU. We would like to be able to have greater reach of this program. So as shown here, basically it's the same idea. We want to have 3 major goals for this is to continue training well-rounded scholars. We want to strengthen our PACU partnership, and we want to further cultivate this programmatic identity of our scholars. The general timeline would be is shown here with the solicitation in 26 and award sometime in spring of 27. In conclusion, I believe that the Pediatric Reproductive Environmental Health Scholars Program is valuable and impactful. It is worth continuing for another 5 years. It has been leveraging the scholars' healthcare knowledge and skills, building their new capacities in research, translation, communication, as well as increasing their environmental health literacy. And in the end, it's contributing to a bigger, stronger network of pediatric and reproductive environmental health leaders. These initial scholars are well positioned to become future leaders in pediatric and reproductive health, where they can work towards improving health for all. So thank you very much for your time and listening and consideration. The discussants for this concept are Drs. Cormier and Mutlu.
Should I start?
Yeah, Dr. Cormier.
Okay, so Dr. Fallon, first of all, I want to commend NIEHS for what I think is a very visionary program. Coming from a rural area where a lot of doctors actually aren't trained in environmental health, I think this is critical, and especially for children and maternal environmental health and reproductive environmental health, because it has long-lasting impacts, not only to the health of the individual, but to the economics of the community providing that health care. So I'm strongly in favor of continuing this. I think it addresses a critical gap in training, especially for clinical professionals. I love the fact that it's interdisciplinary. I like the fact that it's focused on exposures and outcomes that are very timely and relevant to the United States and to the communities in general. And I like the fact that it's working with community responsive tools, allowing the community to be empowered and to affect meaningful changes in their own lives. I think it's an innovative program. I'd like to see it continued. And the only considerations I had were expanding it to make sure that you're including more rural areas, because I think those doctors are critical, because those communities are being exposed. And maybe adding a formal metrics or evaluation to the program as you go along. And I was wondering if there were any plans for NIH cross collaboration with Heart, Lung, Blood, for example, or anything like that. Otherwise, I think this is a fantastic program, and I'm going to leave it to Mutlu.
Dr. Mutlu.
Yeah, hi, thank you, Stephanie. Dr. O'Fallon, thank you for the wonderful presentation. I agree with Dr. Cormier's comments. I think it's a great program. It's very innovative. I would talk about some of the strengths of the program, but the most important part is the gap in research to better understand the impact of prenatal and early life exposure on health. As Dr. Cormier mentioned, this program trains future scholars who actually study the impact of environment, maternal, fetal, and child's health. But as you know, those also determine the health of the person as an adult. So I think the knowledge that will be gained through these scholars is critical to our understanding of chronic diseases, and a lot of them probably start in utero, and environment probably plays a big role. And we have gained some actually information about this through Target 2, and those data will be hopefully published soon. What we have seen that the exposure, obviously these are in mice and exposure models in animals, but we have seen that just in utero and early life exposure in animals led to changes, particularly epigenetic changes that persist throughout the lifespan of that mouse. So I think there's a lot to be learned to improve the health of individuals later in life. I think another strength is the collaboration with the PESUs. And then you mentioned that the program initially asked for just a collaboration with one, but now it's one and more or more. I think that's important, and probably will bring more scholars to the program outside maybe the university that you mentioned. They might be interested in being part of the program. And I also applaud your efforts to increase interactions among the scholars. I think it's important for them to communicate. And I think one of the successes of the NIEHS through the ONES program has been to increase the interactions. And Stephanie and I have been one of the first scholars of that program. I think that interaction is critical for junior people, especially for their growth as investigators and become independent investigators in environmental health sciences. So that's where I think that's all I would like to say. I think it's an overall great program. I hope the NIEHS continues to support it.
Thank you very much, Dr. Mutlu. And thank you, Dr. Cormier.
You're welcome, Dr.
Any other questions, comments from other council members? Olivier.
Thank you. So like my colleagues, I agree that it's critical that we understand better the long-term implications of early life exposure to environmental stressors. The one from the presentation, and I'm not, this was my first time listening to the activities of the program. What I would like to have seen a little bit more discussion of is if I can say it, I'm an economist, I'm going to use that kind of language, a little bit the business case for the program. As you move into phase 2, I would encourage everybody involved with it to think hard about how to measure the impact of the training, and in particular, if there's data and variation in amongst families that are exposed, if I can use that word, to a fresh trained healthcare professional compared to a family where that's not the case, do we see ultimately better infant health outcomes? Because that would be a very powerful test of the impact of the training. But yeah, that was my comment. Thank you.
Right. And so if I can just follow up just very briefly, this morning I was on a call with a pediatric pulmonary fellow at Emory, and I, having prepare for this meeting. Of course, I mentioned this particular mechanism, Liam, and being COP is her advisor. Ben is at Emory, but he's coming back here to Nationwide Children's Hospital here in Columbus, and we're very much looking forward to this coming out, and then perhaps getting her on board with one of the it doesn't matter, Emory or Nationwide. So yeah, I'm very, very much in favor and very excited about this program. I always have been.
Thanks, Dr. Hood. Appreciate that. So, David, can I respond to just a couple of points that were made here?
Yes, do.
So, Dr. Cormier, just real quick, we are in conversations with some of the other NIH ICs, just given, as you point out, there are probably some other ICs that are interested in the same kind of space, whether it's NHLBI and ICHD would be the other logical connection, with a commitment to really training the next generation in reproductive, for reproductive health kinds of issues. So, so yeah, those would make some logical next steps. Dr. Deshane, in terms of the evaluation elements too, I think that those are good points. Keep in mind, we've got barely 4 years of this under our belt right now. So that's really good for thinking down the road. Where do these scholars go? We would hope that through some of the NIH mechanisms that we have, that we would be able to kind of keep track of their trajectory as researchers, whether they stay in the research field or go back into, and stay in the clinical realm, building off of the knowledge that they've gained through this. So yeah, we want to make sure of keeping track of where they go.
Hopefully they stay as clinician researchers.
Yeah.
Yeah. Need more of those. Yeah.
Yes.
I think I would like to add a comment. I think this was discussed during previous council meetings. Physicians discussing exposures with their patients when they see them in the clinic. And this is an issue for adults, when internal medicine physicians see their patients. But I think it's due to lack of time, but also due to lack of knowledge about what the environment can do to your health. I think the lack of knowledge is probably greater for pediatrics, and I think just training these scholars, even if they stayed as clinician researchers, I think is gives us at least some hope for getting environmental exposures as part of their visits when they see their physicians.
That's a really good point, and I would also say that as part of this program too, for example, we saw where they've developed training materials that can be used in the PACU on different timely topics, whether it's fluoride, whether it's these new sweeteners, things along those lines that are responsive to the needs and help to just provide some quick guidances for those interactions. I think that's also a nice step too.
Yep.
Any other comments or questions from council members? If not, may I request a motion to approve this concept?
Move that we approve this concept.
Thank you, Dr. Cormier. And may I have a second?
Second.
Thank you, Dr. Mutlu. And if council members can go back into the electronic council book, and on the agenda tab, you can scroll down to the concept, and following that link, will hopefully let you vote in the ECB.
I see one vote so far.
Where is it?
If you have trouble finding it, just go on the agenda and move down.
Mm-hmm.
All right, the motion is passed.
Excellent. Thank you all. So I think we're a little bit ahead of schedule, but that's not a problem. We'll just add an extra 14 minutes onto our lunch break. So we will be breaking now for lunch. We'll return and start promptly at 12:45 Eastern time for the second concept presentation from Mr. O'Fallon. Welcome back, everyone. I hope you had a good lunch, nice break. So we are back for the continuation of the open session of our September council meeting. And we will have a second concept clearance presentation from Mr. O'Fallon in the Population Health Branch. This is a concept for community engaged research for environmental health. So Liam, I will turn the podium over to you again.
Thanks a lot, David. It's good to be here at the virtual podium once again today. Good afternoon, everybody. I trust everyone had a nice break, whether you ate, exercised, worked, or perhaps took a moment to meditate. For those of you joining us for the first time today, I'm Liam O'Fallon, and I will be talking to you about another exciting and important program focused on community-engaged research for environmental health. Here's a quick overview of what I'll be talking about today, the overall history, rationale, accomplishments, and ending it with a request. I'd like to just start with some acknowledgements here. Although I am the one standing before you this afternoon, there have been many others who made this program what it is today. I want to acknowledge the program staff for their scientific insights, the grants management staff who have helped us navigate the many federal policies, and the scientific review staff who have organized so many exceptional peer reviews. So thank you all. I also want to acknowledge the many community and academic partners who have worked tirelessly together to meet the environmental public health needs of your community members and others who would benefit from your collaborative work. Perhaps some of you are joining us today. Thank you for all the work that you have done and continue to do. So NIEHS has had a long-standing commitment to community-engaged research approaches in addressing environmental health questions. As you may have heard me say before, at NIEHS, we have been seeing so many benefits to community, inspiring the next generation, raising environmental health literacy, informing health practices, protective health practices, building capacity for all partners, and advancing environmental health research. The most recent solicitation of our Research to Action funding opportunity has recently expired, and I want to make the case for the release of an updated 3-year program for fiscal year 26 entitled Community Engaged Research for Environmental Health. For context, NIEHS established the Research to Action funding opportunity in 2009 to promote community engagement in environmental health research, to support multidisciplinary research to collect and characterize information about environmental health concerns of significance to a community, and to stimulate research translation and dissemination to community members, to public health professionals, and/or decision makers to inform action that will ultimately reduce exposures and improve the health of all. The Research to Action program had 3 required elements that I will quickly touch upon in the next slides. The first element was authentic community engagement. Succinctly stated, the primary research question must be reflective of the community concerns. There needs to be evidence that they are true partners, whether it's through key personnel, demonstrated financial support, clearly described roles throughout the research plan strategy, especially in the development of action plans. The second required element was research. We are, after all, biomedical research organization, so there needs to be a research question that is answered. It could be descriptive in nature, or it could be hypothesis driven. There could even be multiple research questions within it, some with more community engagement and others that had less. And the findings of the research needed to be used to inform a public health action plan. Requirement element 3 was the public health action plan. This could include campaigns, programs, and other interventions intended to elicit this change in behavior or practice that would help to reduce or eliminate the exposures, prevent disease and disability, or promote the health of a population. Since its inception in 2009, we have funded 35 projects across the U.S. as shown here. We currently support 10 active projects as indicated by the purple dots. These 10 projects cover a range of locations, communities, and exposures. You can see that they're in the Bay Area, rural Appalachia, Detroit, Sivakak, Alaska, New England, Los Angeles, and rural Indiana. They're looking at myriad exposures from legacy contamination to contaminants in fish, to urban oil drilling, social stress, and wildland-urban interface smoke exposures. They're looking at also a variety of health outcomes, cancer, respiratory health, visual and cognitive function. Often people will ask me about the public health action element, wanting to know what we mean and what is expected. Here are a summary of the types of actions that projects develop. The key is that they are co-created with the community partners to make sure that the actions meet the community's needs. In some instances, the public health action is the co-development of a comprehensive plan that can be used to inform multiple actions or interventions to reduce, mitigate, or prevent harmful exposures or improve health. I want to highlight 6 different projects. I have other nice examples of work that's being done, previous work that was supported through the Research to Action program, but we don't have enough time today. The goal of highlighting these projects is to show the different questions, research approaches, public health actions. I'll try to avoid the granular details of the science. If you are interested in learning more about one or more of the projects, I'll be happy to talk with you afterwards. I'd like to start with a project called Collaborative Research and Action, Empowering an Exposed Community, that builds on the Michigan Polybrominated Biphenyl, or PBB, registry, an initiative that was established way back in 1976 to study the health of thousands of people who were exposed to brominated flame retardants as a result of the largest agricultural disaster in U.S. history. This registry contains a multi-generational cohort of 8,000 individuals, which includes those exposed during the contamination incident, as well as subsequent generations. It's been followed for more than 40 years, and investigators have evaluated many long-term health effects. The Research to Action study was collaboratively developed with scientists, community partners, public health officials, and addressed several major concerns expressed by the PBB community. One, the community members wanted to know if there was a possible treatment to remove the PBBs from their bodies. They were concerned about heritable effects and on their children and grandchildren, and continuing health concerns beyond those related to reproduction. Community members were also expressing their concern that local healthcare providers, theme from our last presentation, seem to be unaware of the statewide PBB exposure and/or its possible health effects. And the community wanted to develop some tools that help to facilitate the communication amongst the healthcare providers and the patients. So what did they do? I'm going to focus in on the first question, which was there a way to accelerate the elimination of PBB and other contaminants from the body? And what they did was they developed an intervention using the orlistat weight loss pill to see if that could help them get rid of the PBBs. The findings were the intervention group did lose more weight. However, As shown here, there was no evidence that the intervention actually reduced the PBB levels in those affected. Now, this is showing a null hypothesis. In talking with the PIs, it was a difficult message to communicate to the community members. But what is important here is that the question that was raised by the community was answered. And that information was delivered back to the community for their understanding. They were heard, they were listened to, and that was greatly appreciated. The second element that they developed in response to the concern of healthcare professionals is that they went ahead and they developed this innovative online community continuing medical education unit, both for healthcare professionals and nursing professionals, to build their understanding and awareness of PBB and other endocrine disrupting chemicals. In addition, they developed a fact sheet for patients to take with them as they went and interacted with their healthcare professionals to help them facilitate conversations. Towards the end of the project in April of 24, the team convened a 2-day in-person community meeting to share the project findings, talk about the CME course, and listen to the community members as they responded to and asked questions about the final project results. The team continues to work with their community partners moving forward. Now I'd like to pivot and go out to Arizona. And the goals of this Solutions for a Changing World is to reduce hazardous occupational exposures and associated health outcomes among small businesses that employ Latino workers. The collaborative research team led by the University of Arizona applied the socio-ecological model of health to examine how they could reduce the exposures of workers in small businesses. This approach stresses the importance of systems to recognizing multiple levels of influence on individuals' behavior. The team recognized that while there are federal state regulations to address some of these reductions of harmful chemical exposures, there are several barriers to accomplishing the goal that needed to be overcome. In the work environment, the ecological paradigm illustrates economic and social pressures that occur for both the worker and small business owners. To address these identified challenges, the team tested a novel promotora, or community health worker intervention, that involved adding industrial hygiene and the hierarchy of controls training into the promotora's work. This hierarchy of controls is complementary and widely accepted model designed to limit workers' exposures. So how did this work? What they found, the team was able to evaluate their scalable intervention, and the results were quite promising. Using the community health workers with their deep community connections, they were able to achieve strong retention rates and identified acceptable VOC exposure controls for both the auto body and the beauty shop workers. I'm just going to focus on the beauty shop results for this. The team found that the beauty shops had about 10 times more total volatile organic compounds than the auto shops, indicating that beauty shops may be more dangerous places to work in terms of exposures to VOCs. The team also achieved larger reduction in exposures due largely to increased ventilation and air purifiers. They found that 87% of the beauty shop assessments had inadequate ventilation, providing actionable evidence for interventions. They presented their research findings to the Pima County Board of Health, and they are now considering recommendations to the Board of Supervisors. So we're seeing some potential for broader public health impacts there. In its 5th year, this project in rural Kentucky is addressing a serious public health issue of drinking water disinfectant byproducts. DBPs pose potential health threats to an estimated 11 million people nationwide. But in Kentucky, this problem is exacerbated in Appalachian communities for 2 reasons. One, nearly all drinking water systems rely on surface water sources that often contain DBP-forming organic matter. And 2, water districts in these counties typically have economic resource constraints, leading them to rely on less expensive disinfectants. Working in Martin and Letcher counties, the team is using multidisciplinary stakeholder consultation to ensure that many community, industry, and scientific voices are at the table for all aspects of the work. The team is studying how environmental health learning is affected differently by participating in the project versus just receiving information about it. They're also assessing how the different kinds of participation in this research may contribute to changes in individuals' trusted communication networks for water quality information. They're working with citizen science to participate in exposure modeling by receiving training of collection tap water samples and interacting regularly with the research team through individual and community report backs. Challenge in rural Appalachia also is that the water distribution systems face challenges, especially with the mountainous terrain, which results in extremely complex distribution networks. To meet this challenge, the team is employing computer modeling to understand the behavior of these networks. Scientists from the UK College of Engineering are working with water utilities to generate hydrological models, creating opportunities for the water districts to predict conditions in the systems that may promote formation of DBPs. These models are being modified to enable the utility operators to examine impacts of changing operational conditions on DBP formations in real time to respond to changing weather conditions, pump failures, or other dynamic changes in the systems. So ensuring participants receive their results is an understandable and in an understandable and usable format is an ethical imperative of this project. As such, the team is providing individualized reports to participants as shown in the center of this slide. Also, in a recent article co-authored with community partners, the team has learned why Eastern Kentucky communities were experiencing higher DBP exposure levels. They discovered that the source water in Martin County, Kentucky has high DBP forming potential due to increased bromide levels. The presence of bromide is likely a result of interactions between underlying geology and land use patterns, and its concentrations are increased by drought. These brominated DBPs are more genotoxic than DBPs only containing chlorine. So not only are these DBPs at a higher level, the overall toxic potency of the DBP mixtures is also increased. So their findings have implications both locally as well as nationally. We've been talking a lot about wildfire smoke today. And so here's a recently funded research to action project that is looking at the exposures, toxic effects, and exposure reduction interventions at wildland urban interface fires. The team is working with the California, Los Angeles area firefighters. They're using silicone wristbands and targeted urinary analysis to help them identify high exposure settings and activities that can guide exposure reduction interventions. The public health actions are being chosen by the firefighting co-investigators. So they were well positioned, unfortunately, but also fortunately, when the January 2025 LA area conflagrations started in the wildland urban interface and extended into the urban areas, the team was able to respond in a timely fashion. As we've seen, for many days, the firefighters were exposed to increased intense smoke, soot, and almost always without respiratory protection. The fire service asked this research team to evaluate the exposures and health risks. The team was suddenly able to work with more fire departments wanting to be a part of their project. Fire department research liaisons met frequently with the academic team to plan each step in the study. They collected urine samples and they followed up and enrolled over 600 LA area firefighters after these fires. Some of the preliminary results of just looking at the LA fires They didn't see any necessary changes in PFAS levels, but the team did note that serum proteins measured, they saw that 60 had changed significantly. As part of this research to action proposal, the team is committed to returning results to their participants within 2 months, and they are still refining the process. The results of their work on the LA conflagration have been submitted for publication, and they're expected to come out soon. This project has been transforming fish consumption advice for the Anishinaabe communities living in and around the Great Lakes. There's been an ongoing concern about the presence of persistent bioaccumulative toxics, PBTs, in the Great Lakes and has led to numerous fish consumption advisories. Fish are an important part of the Anishinaabe diet and culture, and therefore the team has been working to communicate the health benefits of fish, enable cultural practices, but not increase the risk of PBT exposure. So through the Research to Action project, the team updated, tested the effectiveness of an interactive, culturally tailored mobile application called RFish. I will not say it in the Anishinaabe language, which was developed with community input as part of a previous grant. This mobile app delivers personalized consumption advice on species of fish commonly consumed by the Anishinaabe and addresses key concerns related to environmental health and education. Results from their randomized controlled trial with a prospective self-reported fish consumption show that the Anishinaabe community engagement efforts may be encouraging healthy fish, consumption behaviors by getting the word out about fish advisories while promoting living in a good way, which in turn encourages more fishing and hunting. The main effect that the team found was that self-reported increase in the confidence that fish could be safely consumed by favoring lower contaminant fish species and limiting others. And this is a graph from a publication that will be coming out. The last one I want to highlight is focused on PFAS, because so many U.S. communities have discovered PFAS in their drinking water, and they are seeking guidance for interpreting blood and water test results and information on health effects, water treatment, remediation, and strategies to engage with local officials. Through Research to Action, the PFAS Reach team, a collaboration of researchers and communities impacted by PFAS, were able to co-create the PFAS Exchange webpage. This site puts together knowledge and innovative resources to address a multitude of questions and challenges that impacted communities face, covering everything from health effects and exposure reduction to mapping contamination sites, accessing and interpreting blood results, and educating clinicians to improve patient care through a CME course. The website is uniquely centered on the needs of community members as well as communities across the U.S. The team notes that their web analytics also indicate that even communities around the world rely on the exchange as a trusted source of information. The CME course that is offered through the Michigan State University has a pre and post test to document any change in understanding from completing the course, and clinicians can complete the course through MSU for free to receive a 1-hour credit, and the content is also available through a YouTube video. So moving forward, we would like to continue this program. The new Community Engaged Research for Environmental Health program would invite applications from community academic partnered teams for research on potential health risks from community identified environmental exposures of concern. Multidisciplinary teams must employ community engaged research methods, ensure authentic community participation in the research process, including data collection, analysis, translation, and communication. These teams will also co-develop activities that address the community identified questions and concerns, and it would seek to advance our understanding and use of community engaged research approaches in biomedical research, to understand and inform appropriate activities that reduce, mitigate, prevent environmental exposures that may lead to adverse health outcomes, and to ensure the optimal health for all. We do not expect to change much of the focus and structure of the prior programs. The key elements and requirements will remain the same. However, we do plan to change the program name to emphasize the research approach, community-engaged research. Considering the growing support for community-engaged research approaches across the NIEHS hopes that more institutes and centers will sign on to a future funding opportunity. In particular, we would wish to continue working with the National Institute on Minority Health and Health Disparities that has been a partner on the previous research to action, and strengthen partnerships with the National Institute of Child Health and Human Development and the National Heart, Lung, and Blood Institute. We see a strong connection between a new NOFO and the Community Engaged Alliance program that NHLBI and NIMHD have been co-leading since 2020. In the context of potential research topics, we believe that the community engaged research for environmental health is likely to align very nicely with the NIEHS 2025-2029 strategic plan. In conclusion, community engaged research is valuable for so many reasons that align with our shared goals of achieving optimal health for all. As these highlights indicate, for the last 15 years, research to action projects have built trust, they've inspired the next generation, they have raised environmental health literacy, informed protective practices, they've built capacity, and they have advanced environmental health science research. The success of these projects is due to the time, the listening, respect, and authenticity that academics and researchers have brought with them as they have engaged with their community partners. Thank you very much for your time. And now it's time for discussion. The discussants are Drs. Hood and Hornbuckle.
Thank you, Liam. I enjoyed hearing about this work, and can you hear me?
Loud and clear, yeah.
Okay, and I think Daryl is going to start us off, and I'll add to some comments.
All right, sounds good. Thank you, Daryl.
You're muted, Daryl.
You are muted. Yep.
Am I unmuted now?
You are now unmuted.
Okay, great. Liam, you know, I'm the #1 fan of your R2A program, always have been. I must say that as the lead OSU PI for the city for community engagement, CBPR in low-income disadvantaged communities, this has been our template for engagement here in Columbus. And you know, authentic community engagement. So happy to see that. That doesn't always occur, right? And so with regard to community engagement in neighborhoods, we found that the authenticity actually is prerequisite for galvanizing public engagement, which then sustains and leads you to be able to form those relationships and actually impact policy at the local level, right? And so we call that PERT. And so I'm happy to see that. So with regard to research, I think I'll let Carrie or ask Carrie to talk a little bit about what she began talking about this morning in terms of measuring and characterizing exposures. I think she gave us one example. Carrie, would you go ahead and?
Oh, thank you, Daryl. Well, Liam, one of the things that was really striking to me about this program in your presentation today was the timeliness of response. And as a leader of a PCB-focused research center, we often attract attention from communities that discover PCB contamination in their environment. And for example, we have been approached quite a bit lately from communities that discover PCBs in school air as a result of emissions from historical use of aerocolors in building materials. And we are really eager to respond, but the timeliness of response in gathering the funding necessary to do the work that the communities want to do is really challenging. And because we have a Superfund research center from NIEHS, we are able to respond rapidly in many cases. And for example, in Vermont, when they tore down the high school in Vermont, in Burlington, Vermont, they reached out to us and we could go out there right away and help them interpret. And that evolved into a much bigger collaboration. I wonder if you've thought about the opportunity to develop this in a way that responds more rapidly to community response, that like the firefighters example was really striking. They already had the money and then this new crisis came. But so many times that's difficult because you had to apply for the money first, and then the community gets frustrated because of the long time, the lag before work can begin.
Yeah, Dr. Hornbuckle, I think that is an important issue, and that's why there are multiple mechanisms and tools that we have within our research toolbox. And so I think, as you point out, your P42, your Superfund research program, was is another tool that certainly helped and enabled to put you into that position. So I think that there's no perfect approach, but I think there are different ways of leveraging and using the different tools, whereby the work that you described maybe lends itself to a more robust research project, such as what we have funded through Research to Action. Mm-hmm. Does that make sense?
Well, I'm wondering, the firefighters case is so striking, how that has if that's helped you think about how you can turn around the response quicker so that communities could feel more confident that their concerns are being met in a timely fashion. Or maybe this question is not valid. Maybe that hasn't come up.
Mm-hmm. I think timing is a critical issue, Gary, and certainly, something that we do talk about internally. So, certainly some additional food for thought, and I hear the importance of what you're talking about. Yes, this mechanism is definitely where you have much more of a long-standing or trusted relationship in place, where you are able to build off of what's been identified as a critical element. So yes, there's some legwork that's gone into it ahead of time.
All right. Well, thank you very much for considering that. I'll turn it back to Daryl now for his additional comments.
Oh, thank you very much, Carrie. Yes, and so with regard to the health outcomes of concern, I'm very, very happy to see that you took a second look at them, and they've been updated to include some of the health outcomes and conditions that are becoming prevalent in our communities. And I mean rural as well as urban. Endocrine metabolic disorders, the cancer clusters, of course, will never seem to go away. My wife is especially at ISET, and she mentioned one of these, the reproductive health scenario with respect to 8th graders coming up now, showing up in school with this particular condition that you indicated here. Mm-hmm. Men and women, urogenital health, of course, and estrogen. So low estrogen in women from these communities, as well as that increased risk for miscarriages. I think that's well documented, and we're happy to see that. And so the continuation, and one thing I wanted to ask before I continue is now, you are asking for a continuation for these projects for 3 years, or that will be open to new projects?
Thanks, Daryl. So it is for the program as a whole, so that there would be open solicitation for, we're looking for new applications, right? Because there are so many community questions and concerns out there. So this is, again, this would be for a continuation of a new solicitation.
Awesome. Excellent. Very, very happy to see that. And the plans to proceed, of course, yes. I think you were on that call with NIMHD that we had recently. Well, not so recently, 6 months ago or so. So happy to see that relationship continuing to be built with MHD, even though we don't know what the outcome is going to be there, but as well as NICHD and NHLBI. So that's all good. The most important innovation, I think, is how you all have revisited the relationships and the synergy with regard to the strategic plan for NIEHS. So very happy to see Exposomics up there right at the top in terms of that interconnectedness and synergy. Certainly you talked about precision environmental health earlier today, so that's right there. And of course, disparate health outcomes of with an environmental etiology. And some of what does Dr. Worth call them? Extreme weather events. Yes, EWEs, I've been told is how we are to characterize that going forward. And so all in all, I think that this is a significant add-on to an existing significant program that NIEHS has been conducting since 2009. Sure, you're going to get a bunch of applications, and I certainly would be the first to sanction and support this concept clearance moving forward. Carrie?
Yeah. Liam, when I first read the draft description of the plan, I was under the, now I understand, false impression of that you had a rather narrow scope of chemicals and environments that you wanted to track applications from. So I urge you to try to think really broadly in providing examples that this could cover. Daryl mentioned, the extreme weather events, and I think that's an example. I would also like to add encouraging investigators on indoor air, especially school air, and particularly exposures that children, especially children that have existing vulnerabilities, for example, to neurotoxins, as our understanding of the neurological or neurodevelopmental response to environmental toxicants becomes more clear. The environments that our youngest children and pregnant women are exposed to is becoming more of a concern. I'm a PCB person, and I'm very alarmed at our increasing understanding of the relationship between children's exposure to PCBs and ADHD and nervous and anxiety behaviors, and also just in being in schools, noticing the many opportunities for children and pregnant women to be exposed to toxicants in buildings that were built long ago or built without attention to this control of indoor air quality.
So no, those are really good points, and just a couple of thoughts. First, I'm going to just go back to one of your thing about timeliness, and it was brought to my attention that that we do have a time sensitive mechanism too. That's another tool in our toolbox for these quick responses. It's not necessarily, again, the perfect mechanism, but it is one to rapidly get finance or funding out into the community to meet needs, the broader extramural community. To your point about the exposures, again, we want to think of that these are community driven. These are the questions that are coming to the researcher, to the academics, to say, we have questions and concerns about this. Now, so, you know, it really is trying to follow where those, the exposures, the health outcomes from whether it's a geographically defined community or in the instance of the PVB community, more of a community that has been broadly exposed in a wider area. Coming and saying, we've got these questions, Dr. Hornbuckle, how can you help us? You are an expert in PCBs. These are some of the concerns, and being able to work with them to answer questions and you know, having those back and forth conversations to maybe even get, you know, to get some of your questions, you know, answered as well. But it is led by community concerns, community questions about the exposures that they have. So we do try not to limit what the exposures might be because we don't know what they are right now.
Mhm.
Absolutely. Thank you.
Just doing a quick check here. It's almost 1:30, approaching 1:30. Do we know, is Dr. Bhattacharya, does anyone know if he has connected yet?
He has not joined into the Teams yet. Jennifer was just reaching out to his office to see if we had an update on his.
Sounds good. Got it. Okay, Liam.
Looks like Stefania's got a.
Stefania.
So I have a quick question. So one of the things is when we have expedited R21s, I know they're expedited and I know y'all are working as fast as you can, but sometimes it's not fast enough for us on our end. Do you plan to try and make that better? Is there any way to fix that?
That's a separate conversation.
It's a separate conversation.
Okay, yes, we approve the concept.
We're working on some ideas and thoughts, and our expectation is that we will be bringing the time-sensitive concept to our February council meeting to continue this discussion, because I think you're exactly right. It's a valuable program. It's a much-needed program, but I'm not sure it's fast enough.
Yes. All right. Thank you. I appreciate it.
You bet.
Right. And so
questions or comments for Liam from council?
Well, certainly I just wanted to continue. Oh, Gautam, go ahead. You didn't have anything?
No, I don't. I just wanted to, you know,
I saw you.
I don't have any questions. I think it's a great program.
Mm-hmm.
Yeah.
Right.
Thank you, Gautam.
Yeah.
So if I may request a motion from council to approve this concept.
I so move.
Thank you, Dr. Hornbuckle. And thank you, Dr. Hood, for a second. If you could please log into the ECB, go to the agenda tab, scroll down to the community engaged research concept, and there you should be able to access the vote.
Okay.
Dean votes. And the motion is passed.
Thank you very much, everyone. Thank you, Liam, for 2 outstanding presentations, and thank you, council, for your engagement. We do have a few minutes. So Dr. Bhattacharya's office indicated maybe 10 to 15 minutes from now that he will be joining us. So if there are other questions for Rick or I on our presentations earlier, we can open up for some more open discussion with council.
Actually, could I also just add a question on the issue of community engagement to our subject matter experts on council? So as many of you know, with the new administration's priorities, there are certain things, DEI, environmental justice, we can't support that work. That's coming directly from the new administration. So how do you feel that how is this impacting our ability to do this very thoughtful and engaging community engagement? Community engagement is critically important. I mean, Liam presented a very cogent case that we need to continue to do this, and we will. But how do you see that the inability to specifically label something as environmental justice, how is that going to impact our community engagement activities? Any thoughts about that?
Yes, of course, Rick. It isn't. We've been told that the guidance we receive from, for an example, NIMHD or NICHD, NINDS, and the like. And so you have to contextualize it within health, with regard to just public health. That's foundational, that's seminal. If you're going to work with populations, you have to be very, very specific. You will no longer hear or see in my proposals reference to vulnerable communities. You have to be very, very specific. If it's a rural population, if it's an urban population, maybe you talk about census tracts. But yes, the Justice 40, and you did hear me refer to low income, disadvantaged communities, LIDAC communities. That's an EPA designation. But even then, there's no need to do that. I mean, one can simply talk about the health challenges and the public health or the disproportional or the disproportionality with respect to A versus B. That's simple enough. And, it doesn't need another label, right?
So Daryl, let's see if I just want to make sure I'm understanding you. So my sense from you is that just use precise language about exactly what you're doing, and that you can fundamentally, do the types of community engagement that we've always done, just using more precise language. So it's okay. So did I understand you correctly?
You did, and be very, very specific as it relates to your health outcomes, or
correct.
The conditions, as it may be in some instances. But and that should get you where you're going. There's no need, we don't have to use different paint brushes. It's public health, and just keep it simple.
No, that's very insightful. Thank you. It's good to hear that from the experts. Carrie, anyone else on council? We do have a few minutes before Dr. Bhattacharya joins us.
I would just like to echo Daryl's comments. Attention to the health effect that we're interested in requires that we work with communities that are most vulnerable to the effects that we're expert in. And it is often the case that the most vulnerable populations overlapped with our historical evaluation on environmental justice and who that is. And that should still be the case. The science is driven by not studying the people who are not affected by environmental toxicants or injury, but in fact, those who are most vulnerable to it. And so I'm hopeful that the impact will not change because we will continue to work to address those who are most vulnerable to environmental disease and impacts.
Yeah, I think it's, from my personal point of view, that's really the key, Carrie, is really studying those health disparities, and then being more precise in the language that you're using. And so we're trying to do the same things too with climate change. Those are, climate change is, we don't do climate change. And the new administration has made it abundantly clear that any programs with climate change will no longer be supported. So it's being careful and using more precise language about what exactly are you doing. So that's very, very helpful, Daryl and Carrie. Anyone else want to provide an opinion on this while we're waiting for Dr. Bhattacharya?
Just very quickly on climate change, Rick, which that's closer to the work I do.
Yep.
A kind of less charged expression that kind of means the same thing as extreme weather events. I think Daryl maybe was mentioning it before. So certainly, if I were to write a grant application now, that would be that would be the key words that would be using instead of climate change.
That's a great comment. And what we did was, previously, as many of you know, we had a program on the the health effects of climate change. And when we looked very carefully at the work we were supporting, it really wasn't about climate change. It was really studying the health effects of wildfire smoke or the health effects of hurricanes, flooding. And so we're just encouraging our investigators. The work needs to be done. But if you want to be very careful not to use any language that would automatically disqualify you, if there's someone who's looking very carefully at the proposals that are coming in and things that are being funded. Key is as we understand it, is just be precise at what you're doing, and then just continue to actually hypothesize and to be very specific about those experiments, and we can move the science along. Sounds like you're doing that very, very thoughtfully.
If I can actually insert a little bit, I wanted to come back to Carrie's questions on time sensitivity and actually ask Aubrey to come on. Through our health effects and weather program, we're actually supporting 2 NSF efforts that are also kind of addressing some of that time sensitivity issues. So Aubrey, can you come on and speak a little bit about the RAPID and the University of Colorado activities?
Yeah, thanks, David. And as Liam was mentioning, we're trying to think about ways to structure funding to be more responsive and to be able to provide funds, at least quickly, to the research community with other mechanisms like the time sensitive and being able to use centers monies, et cetera. So we have provided funding in partnership with the National Science Foundation to the University of Colorado at Boulder Quick Response Award Program. And this program has historically been funding the NSF research community, especially in the social behavioral sciences response to disasters, to be able to get out the door more quickly. Now they, with NIH funding, are able to provide between 10 and 50,000 within days to researchers with a reviewed proposal. We could provide the link to it to be able to respond. So they've been doing it. It's in place now for over a year. We've put out over a dozen right now of these quick response awards to allow the researchers at least get into the field, get some data collection moving forward, and then build on that with subsequent weather applications for R21s or other types of funding to build further into it, but at least to be able to provide some monies to get going. So we have just proud to say that we're able to just fund that again going forward for FY26. So that just came through in the past couple of days with the National Science Foundation, and the monies now are moving back to University of Colorado in Boulder. So we'll share those links for everybody to see that program, and they're continuing to evolve that. There's a corollary program that goes with it at the University of Washington called RAPID Facility. And that program now just became live really in time for the LA wildfires. And they have now instrumentation for collection of data, but the instruments to be able to do air monitoring and water monitoring and drones and all sorts of types of support for the health research community now to be able to not only get monies from University of Colorado, but also to acquire instrumentation that'll be supported and supplied by the University of Washington. And they actually did go out to the LA wildfires and collect data, drone-based data, observational data, and differing measurements to support this. So we're constructing this, and I think the time-sensitive discussion, as David said, coming up at the next council will be a good opportunity for us to explore the opportunities to kind of put together funding schemes in ways that'll be more responsive to the needs of the research that we want to see collected and the research community that wants to collect it.
Thanks, Aubrey. I wanted to capture that for the public record, since you put that in the chat. So. Any other questions or comments from council? If I can pose a question to council, since we are beginning the process of planning our February council meeting, are there any topics or themes that council would be interested in hearing from us, or having external speakers on to highlight to council?
Was wondering, we've heard a lot, maybe it's just me, my calendar today began the morning with pediatrics and pulmonology. Carrie and I were talking yesterday about what she brought up today, as well as one of the papers we have coming out, tracking 234 3, 4, and 5-year-olds with respect to their readiness to read in inner city child learning centers and across the syndemic. And so, you know, and what that schema looks like going forward. And so I'd be interested in hearing from more of these pediatricians who work in this area with respect to critical windows of development and how what that looks like going forward, and some of the good research that's going on in those areas. You know, you can pick them from anywhere, but there's a lot of good work going on out there, and I think we need to highlight that, and so we can focus on it going forward.
Thank you for that suggestion. Rick, we're now hearing from Jay's office that he won't be on until 1:50, and we do not have a break scheduled between the open session and closed session. I'm wondering if we want to take just a quick 8-minute break, and we can as soon as Jay joins, we can open back up.
Yeah, I think it's good to take a break, but maybe we can take a 6-minute break. So we're actually back in place, so that when Jay, as soon as the minute that he signs on, we're ready to go.
Okay.
I know that Jay shared his schedule with me last week when I saw him in the hallway in Building 1. He's back to back all day today. He may even have another presentation after ours. So let's say 6 minutes. So that puts us well, let's see. Maybe we ought to do 5 minutes.
Let's do 5 minutes. We'll
5 minutes.
Start back up at 1:48.
Good. Okay. See you all then.